Kawasaki disease, KD, is an acute self-limited vasculitis that predominantly affects children, particularly those under 5 years old. Prompt recognition and treatment are crucial to prevent coronary artery aneurysms, the most severe complication. Recent updates in the management of Kawasaki disease focus on timely diagnosis, refined treatment strategies, and long-term management, especially for children with coronary artery involvement. 1. Diagnosis. Updated criteria. The diagnosis of Kawasaki disease is based on clinical criteria, but atypical or incomplete presentations can be challenging. Updated guidelines emphasize the importance of echocardiography in patients with incomplete Kawasaki disease or atypical presentations. Early identification of coronary artery dilation or aneurysms can prompt treatment even when full clinical criteria are not met. Biomarkers. There is ongoing research into biomarkers that may aid in the diagnosis and risk stratification of Kawasaki disease. These include NT-proBNP, CRP, and certain cytokine profiles. 2. First-line treatment. IVG. The cornerstone of treatment remains intravenous immunoglobulin, IV, at a dose of 2 g/kg, ideally administered within the first 10 days of illness to reduce the risk of coronary artery aneurysms. Aspirin. High-dose aspirin, 30 to 50 milligrams per kilograms a day, is used during the acute phase until the child is afebrile, followed by low-dose aspirin, 3 to 5 milligrams per kilograms per day, to reduce thrombosis risk. 3. Ivig-resistant Kawasaki disease, second dose, if the child is resistant to the first dose of IVIG, persistent or recrudescent fever 36 hours after completion, a second dose of IVIG is recommended. Steroids. Corticosteroids are increasingly used as adjunctive therapy for IVIG-resistant cases. Current evidence supports the use of pulse methylprednisolone or a longer tapering course of prednisolone in high-risk patients, particularly those with coronary artery abnormalities at diagnosis or other risk factors. Biologics. In cases refractory to IVIG and steroids, biologic agents such as infliximab or cyclosporine have been used. Infliximab, a TNF alpha inhibitor, is often preferred due to its efficacy and safety profile. For long-term management, coronary artery monitoring. Children with coronary artery involvement require long-term follow-up with serial echocardiograms and possibly other imaging modalities like coronary CT angiography or MRI. The frequency of monitoring depends on the severity of coronary artery changes. Antiplatelet and anticoagulation therapy. Children with large coronary aneurysms may require lifelong antiplatelet therapy and sometimes anticoagulation. Low-dose aspirin is typically continued indefinitely if coronary artery abnormalities persist. In severe cases, warfarin or newer anticoagulants may be considered. Lifestyle and cardiovascular risk. Long-term cardiovascular risk assessment and management are essential, especially as these children age. Attention to modifiable cardiovascular risk factors, including lipid profiles, blood pressure, and lifestyle, is important. 5. Research and future directions. Ongoing research is focusing on the genetics of Kawasaki disease, the role of immunomodulatory therapies, and better predictive models for coronary artery outcomes. There is also interest in the potential use of IVIG alternatives such as gamma globulin subcutaneous infusions, especially in resource-limited settings. 6. COVID-19 and MIS-C. It's also important to note the overlap between Kawasaki disease and multisystem inflammatory syndrome in children MIS-C associated with COVID-19. The management of MIS-C shares similarities with Kawasaki disease, including the use of IVIG and steroids, but often requires a broader approach due to the multisystem involvement. Summary: timely diagnosis and treatment of Kawasaki disease are critical to prevent coronary artery complications. The management strategy is evolving with an increasing focus on personalized approaches, particularly for high-risk and IVIG-resistant cases. The integration of new diagnostic tools, biomarkers, and advanced therapies is improving outcomes for affected children.